Knee pain is an extremely common condition responsible for about 1/3 of all doctors' visits for muscle and bone pain. If you are experiencing knee pain, you'll be happy to hear that there are many treatment options available to you. Here to talk with us about the causes and treatments for knee pain is Dr. Shawn Hocker, an orthopedic surgeon at Atlantic Orthopedics and New Hanover Regional Medical Center. Thanks so much for being with us today.
Thank you.
First of all, right off the bat, let's talk about what are the most common causes of knee pain?
Well, as you pointed out, knee pain is very common, and I think from broad categories, I would probably age match some of the knee conditions. In the early phases of life, we have a lot of quote growing pains. A lot of our adolescents, as they're reaching skeletal maturity, can have diseases or conditions like patellar tendonitis. Osgood-Schlatter's is where some kids, when they're growing very fast, the tendons can't catch up and they cause some discomfort. As we get into I'd say our older years or in adulthood, we see a lot of overuse syndromes where people have the weekend warrior phenomenon and it kind of overwhelms their capabilities, and so we see a lot of that. And then as we get older, without a doubt, the most predominant thing we see is arthritis, which is essentially loss of cartilage that has accumulated over years of wear.
Okay, so that's generally what people who are older deal with.
Exactly.
Right. So if someone is experiencing knee pain, how long should they wait before they should actually go to a doctor to find out what's going on?
That's a very good question. In general, if you're not incapacitated, means that if you have some unpleasant symptoms but you're still functional, I use the 2-week rule. It means that if you are good to your knee, TLC, tender loving care, elevate, ice the knee, take some anti-inflammatories if your stomach can tolerate it, and modify your activities to work within your comfort boundaries, a lot of ailments will kind of right themselves. If you're still having problems after a couple weeks and you see functional consequences, whether that be a limp, you're limited in the endurance or activities you can do, then it's probably worthy of having somebody take a look at it.
So it's always best to try first just to see if it heals on its own, give it a little bit of time.
Exactly. I mean, if you're realizing that it's more unpleasant but not a deal breaker, often annoyances, especially in that middle-aged group, that's so common that often if you let that kind of declare itself, a lot of our ailments that we see acutely probably would have settled themselves out with a couple weeks of observation.
Okay, so what if you have someone who's done that, elevated the knee, iced it, and taken the anti-inflammatories, and they realize, okay, this just isn't going away, I need to go see someone. What are the treatment options for them? Well,
I mean, that's largely based on what the problem is. Even though we carry the term orthopedic surgeons, the vast majority of all of our treatments are conservative. So, you know, in the early going, if you still have an inflammatory response to your injury and there's swelling, we work solely on just make sure that you keep your motion in the knee and you work on swelling reduction. And we may add physical therapy, which kind of ramps up that TLC a little bit more and having some supervision. And then we kind of work, in orthopedics, we look at focal problems, and if we can find something that's focally causing the difficulty and they're failing conservative management, is then we start looking at surgical options.
Okay. So who then would be a candidate for surgical treatment?
So I think that's probably a good way of phrasing that question, because ultimately it's not for surgery, it's not a surgeon-driven decision. It's a patient-driven decision based on symptoms. Okay. Sometimes the injuries are obvious. I mean, if you have a bad fracture, if you're completely incapacitated, you know, those don't have a lot of ambiguity. But if a lot of people are lingering with mild, annoying symptoms, but are still functional and think they're making some improvement, they're probably not good surgical candidates. Okay. But usually I will tell people that it's surgery is based on the patient's symptoms and failure of conservative management.
Okay, so it's nice to hear that it's a patient-driven, or a patient can have a big say in their treatment. And you brought some I guess props with you today. We were talking about an arthritic knee, I guess. So can you show us a little bit what you brought and
Sure.
Tell us what it is?
Well, kind of going from front to back, this is kind of a healthy knee. Okay. So this is just a normal knee model, and I'll hold it up here. And for visual purposes, we've removed the kneecap, which usually runs in the front of the knee. This is the patellar tendon we're attached, so we can look into the knee. We've taken that off to look at this, but this is the femur or the thigh bone. This is the tibia or the leg bone. And the cartilage at the end of the bone here is actually where the game is won and lost. Everything in the knee is designed to support this 2 to 3 millimeters of tissue, both on the femur and the tibia. Those supporting structures are the meniscus, which are the shock absorbers, so every time you take a step, they help cushion the blow to protect that cartilage on the end of the bone. And we also have ligaments. We have the anterior cruciate, posterior cruciate, medial collateral, and lateral collateral ligament. They confer stability to provide an environment that allows that cartilage to articulate without causing shear forces or injury to the knee. So this is a normal knee model, and in looking at this knee model, if we look at our younger injuries, often we will see focal meniscal tears, usually seen by a twisting mechanism in sports injuries. We often hear on the sports radios talk about ACL injuries. That's actually a disruption of the ligament in the front of the knee, where it actually, the tibia translates anteriorly, and sometimes that has to be reconstructed. So as a whole, this is a good idea, a good demonstration of what a good, healthy, normal knee looks like, as opposed to if you have years and years of matriculated wear. This is trying to demonstrate what arthritis looks like. The blue tissue is actually the normal, healthy cartilage, and the red areas are showing where that cartilage or tire tread has worn down completely. So this, in essence, would be where the belts are showing in an old tire. These little knobs here are called bone spurs, and a lot of people will identify to that term. Bone spurs themselves are not the cause of the pain. They're just a reminder that this process has been occurring for years, because it takes years for the body to make these bone spurs. So if we lose the cartilage or the tire tread, that's when we have conditions like arthritis. When you get to this state and you fail your conservative management, then we have treatment options like a knee replacement. And that's what we brought here with this model. A knee replacement is probably better termed knee resurfacing, because unlike this model where we have trimmed the bones above and below for the demonstration, this is not how we've replaced the knee. Essentially, what we do is we shave off a 1/4 inch of bone where the arthritis is at the end of the bone, and we shave it in a shape that mates to this cap. So you have a cap of the femur, a metal cap of the leg bone, the tibia, and then we snap a plastic bushing between these two. So instead of bone on bone, you have smooth metal on plastic. And the same thing occurs at the kneecap. This model has kept the patella. We flip it over, shave off where the arthritis is, and put a cap. So essentially, we're resurfacing the knee, but you still need your ligaments for stability. You still need the tendons that power the knee.
And for someone who goes through the knee replacement surgery, how long should they expect to be out of work or off their feet to recover from that?
Well, as I counsel my patients, knee replacement surgery is one of the most successful things we do, but it is not a quick fix. It does require a lot of energy and effort in the post-operative period with your physical therapist to have a good result. The biggest thing that you're overcoming is that while we are planning or designing knee replacement, the body doesn't know that. And it's responding to the trauma of surgery, and its response is to scar. And so we're working with physical therapy to prevent scarring, to prevent stiffness. And so usually we have formal 6 to 8 weeks of physical therapy after surgery where you're working almost solely on range of motion. If you achieve all the motion parameters you're looking for at 6 to 8 weeks, we pull back from formal physical therapy. But I also counsel patients, it's another 6 to 8 weeks of you going out with your new knee with some anticipated soreness. It's kind of like going to the gym when you haven't worked out in a while. You feel sore, but each time you challenge it again, it gets progressively better. And so we transition to that activity.
So you need some recovery time from this, but ultimately the benefit, though, definitely outweighs everything.
At the end of the recovery period, the vast majority of people wish they had it done years before.
All right. Well, thank you very much for being here, Dr. Hocker, and bringing your props and explaining this a little more for folks. Maybe give someone at home something to think about if they're having knee problems.
Well, thank you
very
much.
Now, if you'd like more information about this topic, visit New Hanover Regional Medical Center's Interactive Health Encyclopedia, where you can learn about the symptoms and treatment options for knee pain. Just visit www.nhrnc.org.